Nice to look out and see so many young faces. I guess the room is divided into the young faces and those of us who stay away from mirrors. I thought I'd think about the money part of this. The Beatles told those of us old enough to remember that money can't buy you love. And Dorothy Parker said, if you want to know what God thinks about money, just look at the people he gave it to. My direct answer to the question posed is that my experience, can money buy change? Not usually. And I will put some caveats to that others have referenced. But what money generally buys us in Canadian healthcare is either more of the same or actually the same with higher pay attached. That's the history of it. Despite all the hopes many of us had for the 2004 Accord, which did achieve some good things. It certainly achieved a silencing of the federal-provincial battle because the federal government stepped up in a predictable way. But other than the money that was very directly targeted for wait times reduction, it really didn't buy very much change. Now, what does money buy? It often buys some amount of experimentation, pilot projects, innovative things which almost never take hold of the whole system because they're sort of ring-fenced as interesting models, but they don't come into the mainstream. Occasionally money buys change, but usually that change, let's take wait times. I think the wait time story is a great success. Although if you really look at it, the change it bought was more volume. So essentially we reduced wait times largely by paying for more procedures. Now, in some cases, there was some significant innovation at the coalface in how to do, if you look at Calgary, for example, how to do more joint replacements without more surgeons and more operating rooms by changing how the work was done. But it is unhappily not the case that more money buys you the kind of change and shared vision of what the healthcare system should look like in the future. And what's striking to me in Canada is there is an extraordinary amount of convergence on the system we need for the future. But there is very little shared view of which lever you should pull or set of levers to get there. And, I've come to the view that you actually get more change when money's scarce. And I'll say this personally, I was Deputy Minister of Ontario in the early 90s when we hit the wall financially across the country, combination of the economy and the federal government putting its house in order. And we had very poor information, and yet we made massive change. The change was largely in the hospital sector, was largely driven by the only two series of numbers we had. We knew what ratio of day surgery to inpatient surgery was going on. We knew length of stay. And what we set out to do was benchmark length of stay, and we took tens of thousands of hospital beds out of the system, closed hospitals. We did that with very little real insight into the impacts. Now, fortunately, the Manitoba Centre for Health Policy gave us all some comfort because they were the only people that did a baseline study before the changes and after, and they sustained the view that the changes hadn't been as damaging as many, it hadn't been really damaging at all to patient outcomes. So we moved 80% of surgery to a day basis. We shut tens of thousands of hospital beds. And those of us who lived through that were supportive of those changes, but I think we all came away with a shared sense that there had to be a better way, a more evidence-based way getting there. Which brings me to the first thing I really want to say. I said to John Horn on the way in, when I realized how large the room was, and I said, I'm old enough to remember when you could put all of the health service researchers in Canada in a rather small room. And it is gratifying to see that over 2 decades we've been able, and you represent many, many others, to build a community in this country that's capable of producing the evidence, has produced the evidence that could let us move in a more thoughtful direction this time. Now, I think it's an open question whether we will, because there is a huge tendency, as you all know in Canadian healthcare and healthcare generally, for the approximately 1 million people who work in the sector to get up every morning and want to do exactly what they did yesterday. And getting them to move off that behavior, and Chris did a very eloquent job of going through in one organization what she's had to do. And I've got to say, anybody who can stand down Tim Hortons has, I hope you haven't tackled the roll up the rim. Then you're really messing with Canadian core beliefs. But I think we're going to be tested in the next number of years right across this country, and financial circumstances are a little different. I'm enormously impressed with what Dan's doing and what his premier is supporting in Saskatchewan, because they don't have quite as much of a burning platform as some of us in the have-not provinces like Ontario have. In addition to not having much of a hockey team in Toronto, we also have no money. And yet, we share a vision of what the health system needs to do. It needs to deal with an aging population with chronic disease, and it needs to do that without packing those people into hospitals. Now, that's because that's been tried. You just have to go to New York City and look at wards full of people with diabetes and realize this is not a model that we want, nor do we want to spend 17% plus of our GDP on healthcare. We've got a few other things like an education system and other priorities. So where do I think we go? And let me just speak to my personal journey. When I was Deputy Minister of Health, the most frustrating thing was not having information, not having timely information, and having ministers who said, I'd like to know if we put $50 million into more pay for doctors, or $50 million into more pay for nurses, or $50 million into an immunization program, or we strengthen the laws against tobacco, what's going to get us the bigger bang for the buck? And frankly, we had very good information on immunization. We had wonderful information. And on the rest of it, not so much. In fact, very poor information. So what we had, and what we had for many decades, was really a competition among groups who all made claims. And their claims were often enforced with political consequence rather than supported by evidence. So if you don't give us what we want, Medicare will die, people will die. Those claims are still raised, and I think many of the groups that raise them genuinely believe them. But what's interesting now is we often have the evidence, so that I believe it was yesterday the Globe and Mail ran an editorial, at least in the Toronto edition, supporting the government's view on some cuts to fees as being well sustained by the evidence produced by ISIS, an organization that I was proud to be involved in founding back in the 1990s. We've built a whole series of organizations in this country. We've strengthened, we started and strengthened CAHSPR, so we've actually got timely information. I won't read the whole list. We just collect badges here and you would know them, but the health councils across the country, CAHSPR nationally, the Institutes for Health Research, we have invested as a country, probably by my best count, somewhere between $1.5 and $2 billion in 20 years in knowing a lot more and having knowledgeable people in this sector. And now the real question is whether the set of changes that we need to make are going to be based on evidence, or they're going to be based on political power, anecdotes, what the minister was told by a cab driver whose brother-in-law owns a lab, those sorts of things, which will always be there and need to be countered by actual evidence. My own journey took me from being a deputy minister to being chair of CAHSPR for 6 years, because I really believed if we had the information, it would just be self-evident what the decisions were. Well, it turns out that evidence doesn't quite trump power in the health system. So my next stop was chairing the Quality Council for Cancer in Ontario, which had the novel idea that clinical leaders needed to be at the forefront. That as an economist, for me to go out and talk to surgeons about their results on doing the Whipple procedure didn't have much impact, because the thought in the back of their head was, listen, buddy, when was the last time you had a scalpel in your hand? And, that's not a story when we would want an answer to. But clinical leaders could go out and talk to their peer group and bring about change if they had the evidence. And actually, the best way to use the evidence wasn't a kind of shame and blame. Why are your outcomes so bad? It was a much gentler approach of saying, we have this data and we're trying to understand it. And then you would see round the table the surgeons beginning to very quickly understand that it meant they shouldn't be doing some things they were doing. And we did see some change, significant change across Ontario. But I really didn't fully understand how all the pieces came together until I became chair of St. Elizabeth Healthcare, which is a large home care organization, largely nurses, which had good, strong clinical leadership. It had a lot of information and became an information culture, but it also had visionary leadership at the managerial level. And I'm of the view that you need all of those ingredients. So you do need the information, you need it translated into analysis and evidence. You need clinical leaders who are willing to go out and be advocates to their colleagues about change. And you need managerial leadership to bring all of the other things gradually into alignment. So do I think there's a magic incentive? I don't. I think this is going to be an enormous amount of very hard work for a lot of people, sleeves rolled up, working with people that they traditionally didn't get on with, because that's partly the nature of our health system, is to blame someone else. So a lot of that, it's embedded in the culture of medicine and nursing, and many of the other health professions have almost a learned, an embedded belief that it's somebody else, if only, and I think everyone in the health system believes if only they had a little more money, right where they are, the world would be better. And that's probably not a bad belief for them to start with, but you need to get people involved in a process. So I think the next 2 or 3 years are going to be a huge test. And I guess I'd like to end on this note. You, people in this room, are going to be hugely important to how that goes and how well we do. Because you, in a sense, have now the burden of knowing things that are suddenly going to be, or very rapidly going to be, right at the top of the agenda. You don't have to go much farther than the front section of the paper now to read about health issues and decisions and choices, and should we pay less for this and more for that? Should we do more of this? How are we going to fund that? And I believe you're going to have to become, to the scope of your courage, advocates for what you know. Because that evidence requires advocacy. And that advocacy is very powerful. I think you don't probably recognize how much power you have in an environment where people who've been elected and appointed are going to have to make some very difficult decisions and choices. And they are looking for a basis for those choices that is rational, that is defensible, and it is something that's going to make the healthcare system in Canada better than it is. I think we all know, including the leadership in the country, that our healthcare system, which is well funded by world standards, is sort of middle of the road on quality and could be a lot better than it is for the resources we've got in it. And I think the people in this room and the people you work with are actually the custodians of that evidence and knowledge. And my request, if I'm able to make a request after all these years, that certainly my advice would be become advocates for what that evidence, where that evidence should take us. And not advocates in the sort of, lectern thumping, I know better than you. But the much tougher role of advocacy is to sit at a table with people and explain what the data and what the evidence means and where it might take them, and let them be part of a process. So don't make yourself into yet another silo. We've got lots of silos. You are, I believe, the kind of detergent that will wash away the silos and leave us with a much better health system. Thank you very much.